You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Shawn McNeil, and today I'm joined by Dr. Michelle Lofwall. Dr. Lofwall is a professor of behavioral science and psychiatry at the University of Kentucky, and she works at the Center for Drug and Alcohol Research. Her recent article in the Journal of Addiction Medicine is entitled Higher First 30-Day Dose of Buprenorphine for Opioid Use Disorder Treatment is Associated with Decreased Mortality. So we are pleased to welcome you, Dr. Lofwall, to the podcast. I'd like to ask you to please start by telling us a bit about yourself and how you became involved in the field of addictions.
Sure. I'm a psychiatrist, and during my residency training, I had great mentors, other psychiatrists who worked in addiction, and had the opportunity to see people with really severe addictive disease get better. So really go from looking like they were going to die if they did not start in treatment or have their treatment changed to address all their needs. And I just found that really rewarding to see that huge turnaround in the quality of their life and to be part of that. So for me, I was hooked early on during residency. I knew I wanted to be a psychiatrist, but it didn't really happen that I became interested in addictive disease until I started my residency.
That's fantastic. So your paper mentions that the first 30 days are a critical time when initiating transmucosal buprenorphine. Can you give an explanation as to what makes this such a critical time?
Sure. So we know that the risk of discontinuation really is very high in the first 30 days. So it's just a very critical time to engage and to try and retain the patient. So, for example, previous work has demonstrated that you have almost like 30% of patients discontinuing in that first 30 days. And so we know also from previous research that dose is one thing that can help retain people in that first 30 days. So among patients who are initiating buprenorphine, there's been some work showing that a lower dose, like 4 milligrams, is associated with a higher risk of treatment discontinuation compared to higher doses. And so really, we were just very curious about what would happen in the first 30 days by dose and then subsequent risk of mortality.
Okay, and that makes a lot of sense. Now, you also mentioned that fentanyl was involved in 29% of overdose deaths in 2016, but a staggering 69% of overdose deaths in 2020. So, quite an increase. Considering that buprenorphine dose recommendations were established a long time ago before the wave of illicitly manufactured fentanyl, as your paper points out, do you believe that dose recommendations should be reconsidered?
I think we always need to look at the science that's been published over time, because we always do a lot more trials continuously over time after medications get approved by the FDA. And so it's important for us to reconsider what was, in the package labeling to see if it has to be updated depending upon, what's happening with the illness and what the new data show. And so I think it's important to consider changes, yes.
Okay, good. Now, were there any changes that you would recommend as a result of the findings in your study? Or do you feel that we need to consider large changes as a medical or scientific community?
So I know the FDA is very smart, and I think that they're very interested in this. They're actually a co-author on the paper, so I think that speaks to their interest. And so, I think that there's things that we could think about. I know that the FDA is also regulated by rules that are promulgated from Congress. And so what I hope is that we can continue to provide more data like this. I know that Kentucky's not the only state that has the ability to link together mortality databases and, their state prescription monitoring programs to really try and provide FDA what they need in order to make changes, so that the changes really we know are going to be safe and efficacious. I think we've known for a long time that there's a population that needs to be maintained on more than 16 milligrams a day. I mean, we saw that in the earlier randomized clinical trial that the NIDA Clinical Trials Network did with methadone and buprenorphine, where there was allowance to go up to 32 milligrams sublingually a day. And a minority of patients needed to be on more than 24 and up to 32, but there were patients that were there. Just like we saw that within our trial, there also were several hundred patients, I think just under 1,000, that were on more than 24, but not more than 32 milligrams. So there's a need. I think the data are always saying that it's not one size fits all, that we need to be giving patients really individualized treatment based upon how they're doing. So I think that's very similar over time. I think the question is are more people needing higher doses than they did before? And one of the problems that we have figuring that out is that there's so many constraints in the real world on dose, like that come from payers and, that don't want to pay for more than 16 or 24. And so even though you might have a patient who you think needs more, they're not going to be able to access more because their insurance isn't going to pay for it and they don't have the ability to pay out of pocket for it. But I think it's really interesting that what's happened in recent years with the new approvals of the long-acting injectable buprenorphine formulations, the brand names Brixadi and Sublocade, and that several of the dose options that are available that are FDA approved really are providing coverage that looks like in terms of looking at serum concentrations that are higher than 24 milligrams a day, especially when you start looking at area under the curve and things like that. So I think there is data to show that it's safe, to be giving higher dose exposures. And so I think it'll be interesting to see what happens.
That's a really good point. Now, your paper notes that Kentucky is one of several high overdose mortality states. What makes Kentucky and these other states more susceptible to these types of problems?
Why are overdose rates so high? That's a really good question. I think there's probably many different reasons and really complex reasons. And, Kentucky is at the heart of where the prescription opiate epidemic started in several decades ago. And so we've had exposure for a really long time. I think we're progressive in a lot of ways in the country. Like, we're a Medicaid expansion state, and we're one of the few in the South that is a Medicaid expansion state. And we, in recent years, have, Medicaid pays for methadone. I mean, that's not a given in every state. So we are making, the policy changes that are needed, I think, to try to make access to care more accessible. I think we still struggle, like the majority of states, with our local jails or detention centers and state prisons with having access to all three MOUDs. There's very few states in the country that actually do have ubiquitous access. I'm thinking of Rhode Island as one of them. And several other states have followed suit with, state regulations that mandate that, because criminal justice is such a large setting where our people with opiate use disorder that is untreated or undertreated have contact with, but yet we don't take action at those places to screen and offer, initiation of treatment and really encourage retention on treatment. So, so we struggle with that here in our state with the criminal justice, getting them, access to care. And we're one of, 19 states and the District of Columbia that still have, buprenorphine regulations at the state level with our Board of Medical Licensure and nursing licensure. And so that restricts access as well.
Okay, that's really interesting. Now, your paper establishes that not only were overdose deaths higher among those treated with lower doses of buprenorphine, but deaths from other causes were higher as well. Now, did you see any trends regarding deaths from other causes that stood out to you as significant?
Oh, so, right. So I wasn't surprised by this, and I think it'll be interesting to see if the viewers think if they're really surprised by this too, right? Like, of course, opiate-involved overdose deaths are reduced with treatment, and we saw there was a reduced risk compared to, with higher doses compared to 8 milligrams or less daily. But, people with opiate use disorder have so many other illnesses too, right? Like other medical psychiatric comorbidity, other substance use disorders. And so we saw, almost like twice as many, or actually, like twice as many deaths from other causes than overdose. And, these included things like non-opioid overdose deaths. So overdose deaths involving stimulants or benzos, right? So lots of our patients come in with comorbid stimulant disorder and have other sedative hypnotic disorders too. We had motor vehicle accidents, chronic lower respiratory disease. We know from the literature that patients who, really have wonderful remission and recovery from opiate use disorder, that one of the most common causes of death is a tobacco-related illness, right? Because there's such a high prevalence of tobacco use with opiate use disorder. So the fact that there's deaths from chronic lower respiratory diseases, that to me seemed very in line with prior work. And then we had over a dozen cases of deaths due to sepsis, which we have so much injection related infections here in Kentucky related to, ongoing injection drug use. And sometimes this is injection of stimulants. It's not always injection of opioids. But, so you get bacteremic and septic, and that leads to endocarditis, osteomyelitis, other kind of deep-seated infections. And so to me, that just really highlighted that it's so appropriate that we have all specialties treating this patient population, because they have comorbid medical and psychiatric and psychosocial, determinant of health issues, which all impact their risk, I think, for mortality. And so I think the data just really showed that, and that was, I think, some of the richness of this data. We were actually able to look at causes of death.
Yeah, and when I read it, I just thought of how much this validates the need for treatment for opioid use disorders. And I also saw in your paper that patients who switched to IM buprenorphine were excluded from the study. And I just was wondering, was there a reason for focusing solely on individuals who were receiving the transmucosal buprenorphine?
Sure. So, we wanted to have enough power in our data. We wanted to be able to really look at the effective dose. And so the injectable long-acting buprenorphine formulations that are all given subcutaneously really didn't come to market until later. And then there wasn't a lot of, not a high prevalence of their use. And so we just really thought it was just going to muddy the waters, especially because they didn't become available. And then when they did become available, they required prior authorizations. And then the way you procure them through specialty pharmacies or through buy and bill, we weren't confident that we were going to see really all of it in our prescription drug monitoring program. So we just chose, for the sake of really trying to just isolate the effect of dose with sublingual product to keep it focused on the sublingual product, which is just really overwhelmingly the formulation that we, I should say transmucosal instead of sublingual, that we are utilizing here in Kentucky over these years. We did have a recent study that we published looking at, injectable buprenorphine, the prevalence of its utilization before and after COVID, and we saw an increase in it, but it's still a really small number of persons that are receiving that formulation.
All right, so I have another question that harkens back to my previous question, and that is, do you believe that there are patient characteristics that would have driven clinicians to prescribe the lower dose of buprenorphine, which then, conveyed a higher susceptibility to overdose? So an example of what I mean is, say a higher functioning patient. Do you think maybe, a patient with a characteristic like that might get a lower dose of buprenorphine, but then, as a result, become more susceptible to overdose?
So that's a really good question, and I think there's probably there's a lot of different practice behaviors that go on that it's hard to isolate one specific factor. We did see lower doses being given to younger persons compared to older persons, and so I do feel like, and younger I mean like 18 to 24, and so I think that there is a general sense of, they're a teenager, we don't want to give them a high dose. I think there's this idea that low is better sometimes, and I think that is perhaps because people keep equating it to like full agonist opioids, where, as you increase a dose of a full agonist opioid, you increase the risk of adverse consequences that include death. But actually, that's not what you see with the partial agonist buprenorphine, right? You actually see a decrease in mortality risk, as this study shows, but also in terms of side effects and human laboratory studies, we've seen ceiling effects on dose, right? Like where you're not seeing increased respiratory depression as you increase the dose. You're not seeing, increased problems with LFTs and that with increased dose. So this is it's a different mechanism of action. I think it's really hard sometimes for folks to grasp that or to remember that. I think there's this general thing that higher is worse, and so lower is better. But I think we need to really correct that's real. The dose that's correct is the dose that's the right dose for the individual. And in general, it looks like higher doses, meaning at least 16 milligrams, might be needed for, or more are needed for folks.
All right. Well, finally, I always like to ask our authors about the implications for clinicians. And seeing as how you are a clinician, I think that, maybe you'd have some good commentary. So do you have any tips for clinicians based on the findings of your study?
Don't be afraid of buprenorphine. It's not hard. I think it's easier than the guidelines for hypertension, which hypertension medication to give people. See it as an essential medication. The World Health Organization considers it essential medication. You can save lives. The mortality reduction is much higher than most other medications that we have in medicine. So don't be afraid of it. If you're prescribing other controlled substances, you should definitely be prescribing this one too. It's great safety profile, great, cost effectiveness, great effect on, reducing morbidity and mortality, and don't be afraid.
Well, thank you so much, Dr. Lofwall, for being a guest. For our listeners, Dr. Lofwall's article entitled Higher First 30-Day Dose of Buprenorphine for Opioid Use Disorder Treatment is Associated with Decreased Mortality. Her article is available in the May-June 2024 issue of the Journal of Addiction Medicine. Thank you for listening.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.